Well, welcome. This is another great edition of our series in getting to know our faculty, and I'm really lucky to have Dr. Pat Murphy with us today from our Division of Trauma and Acute Care Surgery. So, Pat, welcome. It's good to let everyone get to know you. I think in this era of the pandemic, when everyone is wearing masks and surgical caps, this is probably the first time that most people have actually seen your face. So it's really neat. And tell us, where did you grow up, and how did medicine get into your future?
So I grew up in Nova Scotia, Canada, with my family of 5, 2 older brothers.
Yeah.
During my undergrad, I was a bit of a late decider, I guess. In my 3rd year undergrad, I was taking chemistry and neuroscience, and I was exposed to medicine through some volunteer work at our local hospital. And that really influenced my decision to pursue medicine, and I actually wanted to be a neurologist for the longest time.
Wow. Well, the world needs more neurologists, but we're certainly happy that you ended up in surgery. So in Nova Scotia, they have like the tides change there vertically. Isn't that like one of the largest in the world?
Yeah, the Bay of Fundy.
Yeah.
Yeah.
So it's like how many feet you can see with each wave the tide going in and out, right?
Yeah, no, I think I don't know, this is going to be online, so I think it's like 50 feet, I have no idea, but
Wow.
I know the largest in the world.
Yeah, wow,
Yeah.
just fantastic. So medical school, where was that?
No, my medical school was at, geez, I haven't thought of this in a long time, Queen's Medical School in Kingston, Ontario.
Oh, and and was that in Ontario mostly English or French or?
All English.
All English.
Yeah.
Okay. And how did you decide on trauma? How did that come about?
So trauma came about during residency, where I realized that acute care surgery was a specialty. I enjoyed trauma, but in Canada we didn't have a lot of penetrating trauma, so it was largely non-operative. But the times we did operate, it was quite enjoyable, the immediacy of it. And then taking care of what I think is was a forgotten patient population through the emergency room, which no one really took ownership of. The specialty of acute care surgery has really tried to take ownership of that patient population, and they're much more operative, at least in Canada, from a perspective compared to trauma. And so that's how I kind of got involved in acute care surgery, taking care of that patient population.
Sure. And then we're going to come back to maybe the differences in the health systems in a minute. But when did you cross the border and enter the United States? Even though we're close to Canada here, we're not quite at the border.
So as a child, we drove to Disney World one year when I was very young.
Okay.
I have very few memories of that, but I do remember going to Disney World when I was a child. And then I did my Master's of Public Health at Johns Hopkins, so I spent some time in Baltimore during my residency.
Yeah. And what took you, take us from your residency to Milwaukee? How did that all happen?
So during my residency, my plan to be a trauma surgeon or acute care surgeon was actually to go back to Canada after fellowship. And to be a trauma surgeon in Canada, it's not required to go to a trauma fellowship, in the United States, but it can be very helpful. And this is kind of sad, but because of the gun violence in the United States, the rate of penetrating trauma allows you to have more exposure to that disease. And, we do rarely get gunshots and stab wounds in Canada, so it's helpful to have seen a large volume of that in fellowship to go back and train. And then I really stayed in the United States for the pursuit of an academic career in acute care surgery and taking care of penetrating trauma patients and blunt trauma patients.
Sure.
Is still a passion of mine. So to
Yeah.
do that, you have to be in a place that has high penetrating volume like the United States.
Yeah. And getting back to my point about the difference in health systems. So you deal with patients with your interest in acute care surgery, patients who come through the emergency room with all kinds of unexpected problems, oftentimes related to their abdomen, acute problems in their abdomen. And right now in Milwaukee, if they come into the emergency room, regardless of their ability to pay or their insurance status, they get taken care of. How would you would you describe the difference between Canada and the United States with regard to how those patients in the emergency room are managed, et cetera?
I think it's very similar for emergency care in that in both countries, regardless of your ability to pay or your socioeconomic status or where you live, you should get the same care on an emergency basis. The difference comes in the ramifications of that emergency care, where in Canada, regardless of what it costs the system, you wouldn't see ability to see a parking bill at the hospital for you and your family. Whereas in the United States, you may get a large bill for that, and there's financial ramifications for a lot of families if they're uninsured or underinsured. And then on the elective surgery side, there's a difference where, in Canada, you can get your elective surgery, same thing, pay for parking, whereas in the United States, if you don't have insurance, that can be delayed or not performed.
Certainly in Canada, you may have to wait a while for it, though, right?
Depending on what the nature of your disease is, we say elective surgery, but that also includes cancer surgery on a planned basis.
So anything that's non-emergent,
Mm-hmm.
really?
Yeah, so depending on how you consider cancer surgery, whether you consider that elective or not, which it obviously isn't, but it's on a planned basis, that still gets done in a very timely fashion. But for other disease process like biliary colic, that may be in a more delayed fashion.
Sure.
Based on wait lists.
Hip replacement, knee replacement, things like that.
Yeah.
Where do you think, where do you think the field of acute care surgery is going to be in 5 or 10 years? Obviously, I think that there has to be some degree of healthcare reform to make healthcare perhaps more affordable. But any innovations, excluding the financial aspects of acute care surgery, innovations that you think may be a bright spot for patients and doctors and everyone caring for emergency surgery in the future?
So the 3 pillars of my specialty, which is trauma surgery, surgical ICU, and emergency general surgery, 2 of them are a little more mature. So trauma surgery and surgical ICU have been around for quite some time. The field of emergency general surgery, those are the patients who come to the emergency room with appendicitis, small bowel obstruction, acute cholecystitis, perineal abscesses. That's a relatively new part of the specialty, and it's kind of interesting that the specialty has kind of come full circle for what a general surgeon used to be. Taking care of everything that comes to the emergency room, and now it's very subspecialized where there's pancreatic surgeons and liver surgeons and breast surgeons, whereas the acute care surgeon just takes care of whatever comes through regardless of what system it involves. And so I kind of compare it to what trauma surgery was 30 or 40 years ago, in that there's a need for standardization and in particular data collection. So we don't really know what high quality of care looks like in emergency general surgery. We have a hard time deciding on when is the best time to operate on small bowel obstruction, and how quickly can you get a patient to acute cholecystitis to the OR, and should that metric mean something? Should you compare hospitals on their time to surgery or their index cholecystectomy rate for gallstone pancreatitis? So really defining those metrics, but the first step is to collect the data on what those rates actually are at hospital systems.
So much room for improvement everywhere when you really look at it. So last question, what do you like to do outside of work? We try not to give you too much time outside of work. I know Mark DeMoya is working really hard to keep you here almost all the time, but assuming you get home and you're awake, what do you like to do?
Well, funny you ask that. We do in-house call, so that kind of puts a damper on some of the activities we can do on a more regular basis. But more recently, I've joined the MCW resident soccer team, which has been a real blast, just because I've played soccer my whole life, and COVID had put a damper on that for the last 2 years. So getting back to playing soccer has been fantastic. And at home, I have a wife who happens to be a general surgery resident, and a Cavapoo named Charlie, who I love.
Oh, there you go. Great. Well, Pat Murphy, thanks so much. Really great to have you, and we're thrilled you're here at MCW.